Cardio about 20%, but it's probably closer to 30% at this point because detection is improving. This is the data from a little bit older article. So why does it matter? So if you look at atrial fibrillation, so now you're not looking at all strokes, you're looking at strokes caused by AFib. Anticoagulation, compared to nothing, reduces your risk of recurrent stroke, your relative risk reduction, by at least 60% when you compare warfarin to nothing. And then most of us will all do aspirin, right? So I think the more important number is that you have about a 40% risk reduction when you put a patient on warfarin who's had atrial fibrillation compared to if you just leave them on aspirin. And so we'll get into a little bit of the risk factors associated with that, but this was based on a number of trials that have been done comparing warfarin to aspirin in patients with patients who had already had strokes. So we're going to talk in a second about the CHADS2 VAS score, which is a risk stratifier. But patients who have already had strokes, they are already in a higher category, okay? So 1 in 3 to 5 patients, so that's getting to that 20 to 30% number, 1 in 3 to 5 patients have atrial fibrillation as the cause of your stroke. So if you're putting these patients that have already had a stroke on aspirin and that have atrial fibrillation, you're harnessing an additional 40% relative risk reduction. And this is what I tell my patients that are skeptical about going on a blood thinner, and you can't argue with the numbers, right? It's malpractice not to put a patient with a prior stroke and atrial fibrillation. It's malpractice not to put them on a blood thinner unless there's some very overt reason, and that's pretty rare. We'll talk about that in a second. And then that was just warfarin data. So now, of course, we have all the direct oral anticoagulants. We have the rivaroxaban, we have the apixaban, dabigatran, and those are called direct oral anticoagulants because they really work on one area rather than warfarin, which was kind of working all over the coagulation cascade. And these agents are just so much better at controlling the blood thinning and reducing side effects that in apixaban's case, for example, it's superior to warfarin. So your relative risk reduction is most likely even higher. And so that's just to drive home the point, if there were any skeptics, that anticoagulation is required for patients who have had a stroke and atrial fibrillation. Some of you may be worried about bleeding risk, and if you actually look at one of the trials, the Averroes trial with apixaban, if you compare apixaban to aspirin, the bleeding risks were similar. And actually, you can see here that the major bleeding had no real significant difference between the green apixaban line and the blue aspirin line, as did major or clinically relevant non-major bleeding. That's just a vague term. I think we'll just focus on the major bleeding, and those are things like intracranial hemorrhage and major GI hemorrhage, needing a transfusion, that kind of thing. And then one of the things that happens all the time is the older patients don't get put on anticoagulation. So some smaller subgroups of that trial, the Averroes trial, looked at the older patients that were enrolled. And with increasing age, you were still getting more stroke protection and you weren't increasing the bleeding. So that data suggests even as you get older, okay, so you're out here 70 years old, 80 years old, 85 years old, the patients were having, so this is the event rate, so how many strokes were they having? The patients on apixaban were having less strokes, even at the older age, compared to the patients who were just on aspirin, that were having more events. So you can see that difference. And then here, if you look at major bleeding, as you get older, you're still not, and trust me, when you read the article, there's no statistically significant difference between the event rate of major bleeding on apixaban compared to aspirin. You can see for a long time, even definitely up to here, the lines are similar. And then even when you go out to 85, this difference is not significant. So older patients do not have an increased risk of bleeding in this Averroes trial when you compare aspirin to apixaban, one of the newer anticoagulants. We talked about this in a prior meeting. What about falls? How many of you have told a patient or have heard from a patient that they're not on a blood thinner because they're at risk for falls? They fell. They have Parkinson's, something or other. Okay, so we often quote, and many of you have probably quote this old study that used modeling techniques that said you have to fall like 300 times a year in order for fall-related, in this case they actually only modeled subdural hemorrhage, for a patient with AFib on warfarin to have bleeding that outweighed their ischemic protection. And so that's an old trial, and I think it's been morphed now where we just say, oh yeah, you'd have to fall 300 times for this blood thinner to not be worth it. But that's because we're all trying to send that message that falling alone should not be a contraindication. A newer, or it's still small, but a newer prospective cohort trial in 2012 took 500 consecutive patients that came in, that were on warfarin and had AFib. This was in Sweden, I think. And basically the time that they had to first major bleed was no different if they were classified as a high fall risk or a low fall risk. And to define high fall risk, all they did was ask, did you fall once during the last year? If yes, you're a high fall risk. If no, then did you notice any problems with your gait, balance, or mobility? If yes, then you're a high fall risk. If no, then you're low fall risk. So probably all of your patients that you thought were high fall risk would fall into this category. And still, they didn't have any higher significant bleeding risk, major bleeding risk, compared to the low fall risk. And so, these are just some examples. There have been a few more. The data is not perfect, but it's definitely supportive that we should not let fall risk, which I think is the #1 cited cause for why patients are undertreated with AFib, we should not let fall risk prevent us from treating these patients. Hopefully I have believers with me, but we can talk about it more later. And then when we get to why, it's because the power of the ischemic protection is so high. And patients with AFib have such a high risk of stroke. So the CHADS-2 VASC score is the way that we risk stratify patients. And so the more points you get, the higher annual stroke risk you have. So this is like two halves at the side. So just looking at the left side here, the more points you have on the CHADS-2 VASC score, the higher percentage per year you have of having a stroke. And how do you get points? That's the right side. So you have heart failure, hypertension. In this model, there's age 65 to 74, and then you get even more risk as you get above age 75. Diabetes, of course, as we've heard from our folks from the American Diabetes Association. Prior stroke gets you 2 points. And vascular disease means any prior MI, any peripheral vascular, prior MI, vascular disease, or like a plaque in your aorta. And then female sex also gets you an additional point. And the standard practice is that if you have 2 points on your CHADS-2 VASC score, then you should be on anticoagulation. That's everyone agrees on that. If you have 0, but you have AFib, most people, and I'm curious to hear what the cardiologist think, would say you're okay, not on anticoagulation. But if you have 1 point, you should be on an aspirin. Does anyone here that practices put patients that have a CHADS-2 VASC less than 2 on anticoagulation? Okay, talk to me.
I think they're at higher risk.
Is that it?
Well, aspirin's useless. Aspirin's useless. So if you're going to anticoagulate them. If you're not. And you have to look at the other factors. Vascular disease, coronary calcification, does that count as a vascular disease? Not according to the criteria, but I think it does. Certainly a risk. These are all in patients with atrial fibrillation.
Got it.
So then you have to do it against your bleeding risk. And I'm sure you're going to talk about that next.
Well, I'm going to avoid talking about some more because I like this discussion. Who else was talking about putting patients on CHADS-2 VASC of 1 on anticoagulation? Did I hear some murmuring over here?
I tried to, but
tell me about that.
I mean, every time you do this, you're going up against a lot of your colleagues, and you're going up against what the U.S. guidelines say. But I agree with Dr. Adams, and the European guidelines certainly support that aspirin is less effective.
Well, it's not less effective; it's ineffective.
Well, I guess we're always taught
I think you just have a higher risk of bleeding without any risk.
Well, as a neurologist, we're always taught that you get 20% risk reduction with aspirin in anticoagulation in atrial fibrillation. Is that a lie?
Yeah, but you probably get a 40% increase in your risk of bleeding.
Fair enough. The net benefit. Okay, you're a patient. What have you been told about your CHADS-2 VASC of 1?
Just one comment. I would say that are those results that you're quoting statistically significant is the first question, and I don't know if they are.
Which
statistically significant.
The
aspirin, whether or not there's a 20% reduction for AFib patients.
it's compared to the warfarin. I mean, it's compared to the warfarin. So we're just saying that the warfarin is better than the aspirin. But then the aspirin patients compared to placebo did have a statistically significant 20% reduction in a lot of those trials back in the day.
But Matt, if you look at the meta-analysis of it.
Fair enough. Okay. You
So
guys
in
are
the
the experts on
RightCare
that, right?
initiative, there have been fights about aspirin now for about 11 years.
I think our whole question or discussion is, what are we trying to do here? We're trying to reduce an event. And so, I mean, there's enough data there, and then I know the comment was, oh, increase 40% risk of bleed. Well, you showed earlier, yeah, you're gonna have some GI bleeds, but what is really the percentage of an intracranial, you know, a more serious bleed versus outweighing the risk of having an event? I mean, the percentage being so much lower, or what you had showed earlier.
Yeah, and those, I mean, the intracranial hemorrhage rates are low in both now that we have the direct oral anticoagulants. And I think it's really interesting what I'm hearing right now, because I'm not against it at all. I think it's just not the standard of care, which is, what do you do with a CHA2-VASc patient of 1 who might have a coronary CT that shows plaque, which obviously wasn't available when they defined what vascular disease was? And are those a group of young individuals, like Matt, if I can use your first name?
My score is 1, and I just turned 65, so I was told by several doctors, stay on aspirin, baby aspirin. That's my only comment.
So what are the pros and cons of aspirin versus a more modern anti-coag?
Yeah, that's what I'd like to know is, am I wasting my time with
Well, it
baby
has a
aspirin?
higher rate of intracranial hemorrhage. How about if you don't have atrial fibrillation? If you don't have vascular disease, should you be taking aspirin?
No,
Why?
because of the risk of hemorrhage. So I think
Okay,
it goes
then-
back.
so
It
then
goes
that
back
same
to
risk
that.
there if you have atrial fibrillation.
So I think we've unleashed a point, Matt, that you're in this very hot debate, which lacks sufficient data at this time, I think, but based on experience and based on the other data that exists, you know, comparing anticoagulation versus aspirin and aspirin versus nothing in these patients, that the data is evolving and we just don't have the exact answer yet that has come into our guidelines. And so, you know, to answer, are you wasting your time? I think we don't know. A group of experienced cardiologists are telling you, maybe yeah, and why not have a frank discussion with your cardiologist and empower the patients to talk about, hey, should I be on anticoagulation? The risks, of course, are bleeding, but I think the point is that bleeding risks are similar with apixaban versus aspirin.
Interesting. I mean, I'm not a doctor, so please educate me, but there are two types of patients here, right? Acute atrial fibrillation patients like me, I get it maybe once a year. I won't have it for 2 years, then I'll have it, you know, once a week for 3 weeks in a row.
But
And it
that's
lasts for-
symptomatic. That's
that-
when you have symptomatic.
That's mine, symptomatic, so.
Yeah, I think from a stroke perspective, we consider it all just one big bucket, although we understand that the risks are higher in someone like you. But whether you have chronic AFib, paroxysmal AFib, AFib that hits once, that's symptomatic and comes later, for your stroke risk, we include all those patients in this bucket. So
That's really up to debate.
but that's up for debate. Okay, you want to comment on this?
So we
Yeah,
have another cardiologist here who's going to talk about
I mean,
a new way of
there's a
thinking.
whole new field of this thing called atrial fibrillation burden, where they've historically looked at tens of thousands of patients who have implantable devices like pacemakers or ICDs, and they're observational studies, but they've shown that if they have episodes of asymptomatic silent AFib that last longer than 24 hours, their risk of stroke or death is much higher. The odds ratio is upwards of 3 compared to someone who has less than 24 hours. And that they've done studies going between as little as 5 minutes, upwards of 24 hours. So this is not in the guidelines yet, but this idea of treating according to your AFib burden, especially in the setting of an implantable loop recorder, is kind of hot research.
And I think I'll just keep moving so I don't cut into your time, but the technology has basically changed everything. In our group, you know, because of, and we're going to get into talking a little bit about monitoring in a second, you know, what monitoring is significant. If I take any person off the street and I slap a monitor on them and they have 5 seconds of AFib, what does that mean? But as a stroke neurologist, if I'm looking for AFib, any second of AFib is significant to me. So it all depends on your pretest probability, and I think as we get into more of this monitoring data, that's all, I hope, being recorded on these devices and being studied, we're going to understand a lot more. And that's why it's difficult to know what the best recommendation is, but it's all going to change, and we should be a part of that change. So back to our lady in the clinic, why did she have the stroke? We had to ask ourselves in order to select the appropriate therapy. So obviously if you identify athero, then you want to put the patient on antiplatelet, do all the vascular risk reduction that we talk about. But if it's a cardioembolic, you want to put the patient on anticoagulation. So how do you look for AFib? We know from data that, from trials, that monitoring longer is significant to finding even paroxysmal or silent AFib, and that in patients that were above 40 that had an uncertain cause of their stroke, when they compared conventional, serial EKGs or 48-hour Holter monitoring to a link monitor, which is an insertable cardiac monitor, the detection of AFib was almost 9% at 6 months compared to 1%, which was very significant. To save time, I won't talk about the other trial, but basically 30 days, 6 months, maybe years of monitoring is definitely better, and 48 hours of monitoring is malpractice.
It's malpractice.
So 1 in 4 patients, however, will not have an obvious cause of stroke. And why is that? Is it because their workup revealed no cause, multiple causes, or was it, which is most often than not, an inadequate workup? What constitutes inadequate workup? When the imaging appears embolic, and I'm not going to go into too much detail, but it's just like where the stroke is on the MRI and what its shape is and how big it is, those patients are called ESIS now, or embolic stroke of undetermined source. That's that undetermined cryptogenic category. And I'm bringing it up because, this paradigm, which is a whole debate in my field, helps to define what inadequate workup might be. And in trials, they say, no athero, more than 50% in the same vessel that led to the stroke, no obvious structural